Well, good evening. Thank you for the opportunity to be here with you this evening. Now, there's a couple of burning questions that we need to ask and answer right here at the outset. The first has probably been on your mind as you thought about coming to this and deciding whether or not you were going to come tonight, considering other more attractive alternatives, I'm sure, and that is, why is an insurance company CEO doing this talk? And your follow-up question is probably, what in the world could he possibly know about technology? When the invocation came, I asked myself those two questions. Why would they want me, and what is it that I'm going to say about technology? Well, the answer to the first question is pretty short. I got invited, but I got invited after Glenn Tolman had to cancel. Glenn's the former CEO of Allscripts and a really good friend. And so it was fortunate for me that he had to cancel, and I did get the invitation, and I do appreciate the fact that I'll have this opportunity to talk with you this evening. Now, as for the second question, what about technology? The answer is about what you would expect from a 59-year-old insurance company CEO who, when he graduated from law school, there weren't any computers in the law library, and that is not much, except for the fact that I can operate my iPad and my iPhone, but not very well. So I did turn it off, however, and that's about it. But I thought that it would be interesting tonight to talk about health care, the challenges and some of the transformations that are taking place, and that will indeed we will integrate a technology conversation about some of the things that are beginning to happen in healthcare that directly relate to technology. And so for about 15 minutes or so, I'm going to share a few thoughts and some examples. But I really want this to be your program. I had rather respond to whatever questions that you might have. Hopefully there will be more healthcare questions than technology questions. But out of that, typically, we all learn more together. So think about what it is that you would like to explore. Feel free to interrupt me as we go through the conversation. Now, I hope you are aware, and I certainly know, that we have a host of challenges when it comes to addressing healthcare costs and improving the quality of care. And throughout the talk tonight, we're going to talk about those two things together. Cost and quality. And we're going to have to remember now, as citizens that are working on this issue, that every time we're in a conversation about it, those two ingredients need to be tied together. Health technology, health information technology, can and should and will play a huge role in making our healthcare system better as we think about the two components of higher quality and lower cost. So that's what I really want to talk to you about this evening. We'll have ample time at the end for questions, and I look forward to your provocative and informative thoughts. Now, I want you to think for a moment about how technology makes you a better and happier consumer. And I'm sure you can think of a number of examples, but let me prompt you with a few. Amazon. You can do all your shopping and purchasing with just a few clicks. Netflix, you can watch whatever movie you want to watch whenever you want to watch it and pay for it however it is that you want. Online banking. You do all your monetary transactions and you never have to go to the bank. And of course, smartphones and apps. In the palm of your hand, you have more computer power and capability than the astronauts on the Apollo 11 spacecraft. And that's pretty remarkable, particularly for those of us who can actually remember Apollo 11. So now let's extend that thinking. A happy and satisfied and nimble consumer Deploying and leveraging technology. Let's think about that in the context of healthcare. What do you typically see when you walk into a doctor's office or into a hospital waiting room or emergency room? Well, I don't know about you, but more often than not, you see a bunch of colored folders with papers jammed inside, people running around carrying them. You see these patient charts, you see them opened up, and if you're like me, you really have to wonder what is actually written down and is it accurate? And how old is it? And is all the paper there? Now, that's not a pejorative statement about our great physicians who render such wonderful service to all of us, because that's how they were trained, and they're trapped in that environment in many, many circumstances. But one thing is, it doesn't exactly inspire great confidence that they've got all of your health information right. And each time you have an interaction, each physician needs all of your information. Well, the point is, we got a long way to go. And there's a tremendous opportunity to leverage technology and data to improve health and reduce the cost of medical care. Well, if you haven't heard it, I'm going to declare it here this evening for you. We have a crisis in health care in this country. Costs are going to go even higher than they are today. And unfortunately, we're simply not getting good value out of the health care dollars that we spend today. And the trend line is that that's not going to cross anytime soon in the near future. So let me run down a few of the challenges that we face in the healthcare system today. Medical spending represents approximately 18% of the gross domestic product in the United States. And according to the Congressional Budget Office, it's going to hit 20% by 2020. So think about a $5 bill in your pocket, and by 2020, $1 of that $5 bill is going to be dedicated to covering healthcare costs in this country. What we spend today on healthcare equals what France, which is the 5th largest economy in the world, spends on everything. And we're not getting what we pay for. Life expectancy in the United States is 38th in the world, according to the United Nations. And think about this, unhealthy lifestyles. We're all in charge of our own health. They are taking their toll. At Blue Cross and Blue Shield of North Carolina, about 20% of all the medical claims that come in to our company that we pay are related to diabetes and obesity-related conditions. Now, to put that in real monetary terms, that's $2.4 billion out of the total $11.8 billion that we pay every year. And medical technology, in the form of sophisticated equipment to help doctors diagnose and treat disease, can account for as much as half of the increase in health care costs, according to the Kaiser Family Foundation. So here's the irony. Here's the irony about technology. Technology is typically thought of as a way to improve efficiencies and reduce costs. And indeed, often it is. And it certainly holds a lot of promise when we introduce new health information technology, things like electronic medical records, healthcare data, and online tools and smartphone apps for consumers. They're here and more's coming. What drives up cost is medical technology, the sophisticated equipment and devices that you see when you go into a doctor's office, outpatient clinic, or into a hospital. But let me be really clear on one point, and I don't want anybody confused on this. No one, and I certainly am not, I'm not suggesting that we should do away with these medical technologies that help save lives, improve quality, and advance care. That's not an option. But what we do need to recognize is that great medical care is not free. It costs money. It is expensive. And we need to use and deploy these new technologies wisely. So what we do at Blue Cross, on behalf of our customers, we take time to review clinical evidence that new medical technologies and new medical procedures actually do what they're intended to do. Are the marketing materials accurate when the newest and latest thing comes out? And we do that to try to ensure, looking at the medical evidence, that these technologies give patients better care, better than the old technology. It's actually advancing the ball. And only then do we make a decision to cover them. Because when a decision is made by us to cover something, that means money will be transferred from our customers to the person who's delivering the service, and you want to make sure that the bang for the buck is there. We also need to recognize that just because someone comes out with something new or a new technology doesn't necessarily mean that it is in the best interest of the patient. Things take time to improve. And we've got to get smarter about that. We get calls and letters all the time about the latest and greatest new technology that's 4 times the cost of the old technology that somebody wants because it's new, when the evidence is clear that there's no difference. It's not any safer, it's not any better, it's not any more effective, it's just newer. Now, while we have our share of challenges in healthcare, we also have unprecedented opportunity. One of the things that I'm excited about the passage of the Affordable Care Act is that it in fact stimulated and started a revolution in healthcare. There has been more change since March 23rd of 2010 in all matters and things in healthcare. Most good, some neutral, some bad. But the change is happening, and it needed to happen. And at Blue Cross Blue Shield of North Carolina, we are at the forefront of building a better healthcare system. That's part of our mission, part of our calling. And we're looking for one that improves the quality of our health care, it manages rising costs, and makes things better for patients. And as we work towards this better system, we're seeing a great deal of collaboration take place across North Carolina. Gone are the days when the group of physicians can go over here, and a group of hospitals can go over here, and the insurers can go over here and do their own thing and try to fix the system in their own unilateral way because it doesn't work. One thing that the ACA has done is it has brought the parties together at the table to try to figure out how to transform healthcare in our state. And we have a role to play. We're one of the largest healthcare entities in the state. And our goal is to make healthcare better by making it more patient-focused, more collaborative, innovative, and effective. And so let me share with you a couple of examples that we're already engaged in. Carolina Advanced Health is a new kind of medical practice that we opened between Chapel Hill and Durham just over a year ago. It is a partnership. It was built jointly with the UNC healthcare system. And what it does is it brings together medical professionals who put patients at the center of a team approach. So far, Carolina Advanced Health is getting rave reviews from patients, the ones who really matter, the people that are walking in the door and experiencing the innovation in the care. And here's one just quick example. A gentleman in his 40s who lost 33 pounds saw his blood pressure and his cholesterol numbers drop significantly in only 8 weeks. And his encounter there was with a primary care physician, a nutritionist, a PA, an electronic make your appointment online. When you go into the waiting room, it's not much bigger than this right here because people don't wait. It is a new model of care, and it is making a difference. In another innovation, we've helped pioneer a new way of paying hospitals that gives them a strong incentive to provide quality outcomes for their patients. It's called episodic bundled payments. Remember that phrase. You're going to hear it. It's coming. There's going to be more of them. Episodic bundle payments. Right now, it only applies to knee replacements. We started doing this with Caramount Health in Gaston County a couple of years ago, and just recently we've added both Duke University Medical Center and Triangle Orthopedic Associates as partners in this new way to pay for this type of care. Now, under the traditional way of paying for hospitals, they charge us for each procedure, each activity. Every time the wheel turns, there's a click on the bill. If the patient develops complications after that episode of treatment is complete, we keep paying them for whatever else it is they do for the complications. That's the way the current system works. Now, this way of paying is a perfect example of what is wrong. Doctors and hospitals are paid for the volume, for the amount of things that they have done, rather than for the value of the quality outcome that the patient and all of us want to receive. Now, under bundle payments, it doesn't work that way. The way that works is we pay a flat rate one time. Knee replacement costs X. If there are complications, readmissions, or other problems, the hospital cannot charge any more. The hospitals we've partnered with like the arrangements because these institutions are and have been focused on quality. And when they deliver a quality outcome, they have set a rate where they make more money because the savings is between what it costs them to deliver that quality outcome and what we have paid. And we've also started offering on-site customer service at several hospitals. One's here in Raleigh at Wake Med and the other one's at Wake Forest Baptist in Winston-Salem. So if you or a loved one end up in either of those two institutions, the last thing you need to worry about is what's covered, how much is it going to cost, will it be paid, how's the claims going to be filed. And so what we have done, and we're going to continue to do across the state, is put on-site customer service folks like Erica Holloway, who is our person at Wake Med. She's there to meet with family members, go check on folks, answer their questions, help them navigate their way through the system to make sure that it's all working well for them. And I hope that you'll notice that with each innovation, that we're at the table with a willing partner. We didn't dream all this up by ourselves. Carolina Advanced Health was spawned out of a conversation that I had with Dr. Bill Roper, who leads UNC Healthcare System. We knew each other from other lives. And when he called to congratulate me on my new role, he said, let's get together and see what's possible. And out of that meeting came an idea. And then, like all great leaders, you get a bunch of smart people together, get out of their way, let them do their work, and Carolina Advanced Health was born. It takes willing partners, and we're fortunate here in North Carolina that we have a lot of them. To paraphrase Dr. Atul Gawande, who writes about healthcare in the New Yorker magazine, you can't be a cowboy in healthcare today. You got to be part of the pit crew. And that's a wonderful metaphor about how we're going to continue to transform healthcare in this state. Now, the innovations I just described depend on establishing new ways of doing business. But they also depend on a heavy dose of health information technology. For example, using health analytics to determine the best course of treatment for patients at Carolina Advanced Health. That team takes a lot of time talking with each other and studying the clinical data and doing heavy analysis on it to make sure that they have the right treatment plan for each individual patient. Meanwhile, there are some innovations. Some innovations have data and health IT at their core. For example, we started a partnership on electronic health records with Allscripts, the provider of health IT that has a big office here in Raleigh. Through that partnership, we are providing electronic health record software, training, and support to 750 independent physicians and 39 free clinics across the state. Why? To try to achieve the goal to improve care by reducing medical errors and minimizing redundant procedures. We've partnered with Allscripts because both of us believe it's important to help independent physicians, the ones not owned by hospitals or large healthcare systems in our state, to have access to the same procedures and resources that other practices have. We also have a collaboration with SAS Institute that will give us more insight into customer-specific health needs. This is going to be and promises to be a very, very important tool in engaging consumers in improving their own health. Using the analytics provided by SAS will help us develop products and services such as health management programs that better meet customer needs, and will also be able to better target customers who may benefit from these programs and more effectively make them aware that they are available. Now, the work we're doing with SAS is the kind of thing that you need to keep your eye on as students in this discipline, particularly at this university. We're not alone in this space. Other insurers are beginning to tap into and analyze their data. And I certainly can't wait to see how far it takes us in managing costs and improving quality. These analytics will help us develop ways to focus on the prevention side more effectively than we are today. So how does all this work together? Well, the bottom line is they all hold great promise for making the whole system better, but not every initiative will work. Not everything will be perfect. Many of these things are lab experiments, and some will be wildly successful and some are going to fail, but that's okay as long as we're learning from our failure. In any case, the only way we're going to know we're succeeding is by measuring results and analyzing them and making sure that we're doing that with the sophistication of health IT and data. The one thing is for certain, if we don't figure this out together, and if we don't try new things and be willing to be bold and challenging, we're never going to solve the vexing problems that we are facing. And if you remember the cost trend that I mentioned, we can't afford it as a country. We can't raise enough money. We can't reform taxes enough in order to pay for the tsunami that is coming if we don't change the trajectory of healthcare costs. So let me offer this to you in closing. As I said at the outset, I'm not a technology expert, but many of you are, and that will be your profession. And I'm glad that you're here, and I'm glad that that's where you're going, because you're going to be critically important to solving this problem. Those of us that are more in the healthcare field and the technology field certainly need your help. There are many opportunities for innovative thinkers who can figure out how technology, data, processes, and systems can be deployed to reduce healthcare costs and improve quality. For the students here this evening, if you're considering a career in healthcare, you've got a lot of good choices in front of you. The analytical and problem-solving skills that you've learned here at NC State will not only serve you well, but will put you at the top of the list when people are looking for folks that have your skills and abilities. And that's exactly what we do, trust me. If you haven't thought about healthcare, consider it. You might find opportunities in some places you never even thought about, including our company. And I would encourage you, if you're still in the job market, trying to figure out what it is that you want to do, number one, we have an internship program. So last year we had about 25 college students from across North Carolina, from all the institutions. It was a wonderful experience for them and a wonderful experience for us. And if you're beginning to move out into, quote, the real world, check the career section of our website, bcbsnc.com. And if you go on there tonight, you will see many openings for informatics analysts, business intelligence developers, enterprise business analysts, business solution developers, etc., etc. And that's probably right in some of your wheelhouse. For everyone else, we invite you to join us in trying to make the state's health system better. Take better care of yourself is the first step that you can take. We're always looking for new partners. And as I stressed a moment ago, none of us are going to be able to figure out this alone. We certainly welcome your ideas. We invite you to go to another website that we have called letstalkcost.com, where you can engage in a dialogue about what's right and what's wrong with the healthcare system and post your own suggestions. And trust me, we get lots of great ideas through that avenue. So I believe that like never before, the revolution has begun, and a key ingredient of that will be health information technology and data. It is absolutely poised to change healthcare for the better, and it's a wide open field. So with that, I look forward to continuing our conversation. Happy to answer any questions about anything I've said or any other subject that may be on top of mind. And again, I appreciate the opportunity to come and talk to you this evening about healthcare and a little bit about technology. So thanks for the opportunity.
Brad, you'll take some questions.
Oh, absolutely.
And will you repeat the question for the video? Thank you.
Yes, sir.
The banking industry and related financial industries have achieved a level of standardization in data transactions that allows me to make payments and have transactions across institutions. You know, it's a long road to get to standardized health histories, for instance. Every doctor's office I go into, I start from scratch. Right. There's a lot of independent programs that maybe this practice or that hospital has embraced, but I'm wondering, how long do you think it's going to take to get to standardized, transferable, integrated data formats, and what are the major inhibitors to that?
It's a great question. The point was made that in the financial industry, the banking industry, standardization took place a long time ago, which enabled the banking industry to be more technologically advanced than you do online banking because it's basically one format. So how is that going to translate into healthcare? Because the healthcare is not like that. There aren't any standards, or there aren't many standards, and it's certainly not uniform. Does that capture the essence? And how long do you think it's going to take us to get there? Well, the honest answer is I don't know how long it's going to take us to get there, but you have hit on a central challenge that healthcare has. So let me tell you what I do know. The interest and acceleration and initiatives around trying to standardize the baseline data that one would need, or that the healthcare industry would need in order to be more like banking, has begun. In fact, I was involved in a conference call yesterday that just in a payment transaction setting, so where you could go to the doctor's office, swipe your card, the money is transferred to the doctor's office that night, and you get out of the whole paper claims business. Right now, there are 31 companies in America that are in that space in varying degrees of sophistication. And what will happen over time is most of them will be unsuccessful and fail. But those that are successful will learn from those failures, and there's some that are really onto something following that banking model. So talking about just the payment system side of healthcare, I think we're going to get there, and I'm just going to pick a number, but understand I have no substantive basis. I think we'll be there within the next 3 to 5 years. Now, will it be pervasive across America? Probably not, but it could be on a state basis or a regional basis. Now, as it relates to the transfer of electronic medical records, I had rotator cuff surgery last year. I know how many forms you got to fill out every time you go in and have a check, and it's the same stuff. I mean, you just go, why is this necessary? But the point is, we're further away from that. And one of the challenges of that is because you have virtually every hospital, every physician office has its own system. So they've got capital investment made into those systems that they don't want to give up. And by the way, it's familiar and convenient. One of the components of the ACA is through economic incentives, encouraging states to build an electronic medical record backbone. And that is being done here in North Carolina. That once those states embrace that, take that money and figure out and build the electronic medical record backbone for the state, that's like building the interstate system, if you will, across and through which all of these disparate medical records can run. Now, in North Carolina, again, the hope is that somewhere in about 3 to 5 years, that backbone is going to be up and running the way we want it to. But we will see. It's a long journey. From a national standpoint, I have no idea, because you start thinking about moving that across 50 states, and right now, with the continuing emotion that surrounds the ACA and some states being very progressive and moving forward with the implementation of health care reform and others not, there's always going to be a little flat spot on the wheel. Let me make one other point, and I don't want to get too technical, but this is important that you understand. Currently, when you go to the doctor's office and they hand you the pink sheet, and it's got all these little codes on it, and they've colored things in. Everybody remember that? That's called an ICD-9. And that has been adopted as the way that physicians will diagnose. So they color in a diagnosis code. And that is how they get paid by us. That goes through the system. Well, there's an ICD-10 that by October of 2014, everybody in America, every provider in America is supposed to be ready to implement and use. It's going to take the number of diagnosis codes from something around 14,000. I think that's the number under ICD-9. But I know I'm right on ICD-10 to 149,000. And the rule today is that if we get a claim in and it's not on ICD-10, we're to reject it, not pay the provider. And I can tell you that there aren't many providers that are ready for that or will be ready for that. Until you solve that problem, so you've got everybody using the same information system that's going, or billing, coding system that is going into the IT system, it's going to be a daunting challenge to get to where we're going to do it like electronic banking. So I think you're going to see it solved in bites. Payment system, electronic medical records, and then this foundational piece. Sorry for a long-winded answer to a very good and central question, but that just shows you how complicated it is and how far we've got to go. Yes, ma'am.
You mentioned the Affordable Care Act in the beginning of your speech. I was wondering if you could expand a little bit more on how that's affected your company specifically in North Carolina.
Okay. The question is, how did the Affordable Care Act, how has it affected Blue Cross Blue Shield of North Carolina? Well, so far, there hasn't been all that much dramatic impact to our company, because a lot of what was adopted in that statute in terms of expansion of coverage, for example, students staying on their parents' health insurance until age 26, we were already doing. We've been covering the 26 rule since up to age 26 since, I think, 2007, 2008. Now, 2014, as it approaches, is going to be a big deal. And let me just give you a couple of examples. You've all heard about the exchange, the health exchange. What the Act says is that there will be a health exchange, think about it like a shopping mall, available to everyone. And if you are a health insurer and you want to sell your product on that exchange, then here's what it has to look like. And they tell you exactly what the products are going to have to offer at 3 various levels. A minimum. You can put more in it, but it's got to have at least these various components: bronze, silver, platinum. And everybody, or the federal government, and many states are hard at work building the IT system that will cause that exchange to appear on your computer screen. Now, the idea there is that you as an individual consumer can go to your computer and shop online, compare us against Cigna, Aetna, United, whoever the other competitors are, and you'll get an apples-to-apples comparison. You'll know that the bronze product from Blue Cross is the same as the bronze product from United, which is the same as the one from Cigna. And you'll be able to see the price of it, and you'll be able to make a decision on what it is that you want to buy. And then when you push the buy button, if you are eligible for a federal subsidy to help you pay for that premium cost, that it will be calculated in that system so you know what your bottom line is. And by the time you finish the transaction, you will be enrolled as a customer of our company. We don't do that today. You can go to our website, you can put in your information, you can get a quote, and then the transaction is after the quote. So how has it affected us? Number one, we're designing products in order to be eligible to present and sell on and through the exchange. Number one. Number two, we are preparing our IT system to be able to plug into and interact with whatever the government it is that they're ultimately going to build that would make that transaction work. And then, of course, we are preparing to service that customer, not only in the way that we currently do, which we do the best job we can every day, but to the extent that that creates other iniquities, we'll respond to that. Let me give you one other example that also makes a cost point that's very, very important. Our company will pay an additional, over time, an additional $78 million in federal taxes that we are not paying today. That impacts our company. That's going to impact our customers, because that tax will show up in the premium bill. We can debate whether that's a good thing or a bad thing, but it is. And one other example would be in the federal law, there is a proposition or provision known as the age band. Not to get too sophisticated, but think about it this way. The law says that our highest premium can be no more than 3 times the cost of our lowest. The theory there is, with that, the enactment of that provision, that folks that are more like me, at the upper end of the age scale, will have lower premiums. And that's true. A certain small subset in that upper end will get, probably, most likely, will have some lower premiums. But think with me, if you will. Some of you have probably had a lot of economics courses. What do you think that's going to do to the cheaper premiums? It's going to drive them up. So here's a real-life example. These are approximations. Healthy 25-year-old male in North Carolina can buy an individual Blue Advantage policy today in North Carolina from us with a $2,000 deductible for about $130 a month. The age band alone is going to move that price point up to about $365. That's going to affect our company. That's going to affect all of you. I see more faces that are closer to 25 than 59 in the room. Now, again, we can debate whether that's a good thing or a bad thing, but that is the reality. The list goes on. We will be prepared. From the first time the statute was enacted, our philosophy has been we embrace it. We're going to make it work as good as we can, as effectively as we can on behalf of our customers. We're going to advocate for the things that need to be changed in the law that will make it more effective and efficient. And we're going to keep serving our customers just like we have for 75 plus years. No piece of legislation when it was first enacted was perfect. Social Security, Civil Rights Act, the Sherman Antitrust Act, you name it. Nor is the ACA. So while there's a lot of good, opening up access, bringing people into the system, that's terrific. There are things in there that are we are all going to have to work on and struggle with to make sure that we are moving forward and not backwards. Other questions? Yes, sir.
Yeah, I work in a technology. I'm inviting me from Safety Systems. We do deal with your company business and building an infrastructure. So I'm familiar with all of the stuff you said.
You should be speaking.
My mind is, I'm thinking about, well, why, there's a law in electrical engineering, it's called Moore's Law, which reduces the cost and increases the function cost. This is healthcare. So, I'd like to apply it because I want to bring that conversation into the, I think a lot of these challenges, they have to do with leadership. If I can produce a gadget like an iPhone or a laptop so cheap, why I should not be able to produce an MRI, a scan machine, the same cost, or maybe a gene gun, with reasonable cost. I think the baggage associated with the challenges of the lawsuits, the court system, the FDA, all of that goes along with it just adds up to the cost. Mm-hmm. For me, if I consider my garage or in Cisco Systems lab, I can design the coolest, technology. And computer science kids, they can really write that code, and they can do it. And it's doable. It's not impossible. And what challenges us is those hungry lawyers, they're sitting, and they're trying to sue the insurance company or bring that benefit. That increases the cost for the suppliers of the technology and the vendors. Sure. And that's a huge challenge. That's the biggest challenge. I think it's a leadership challenge. It's not a technology challenge.
Sure.
I'd like to hear you.
Okay, sure. Well, let me capture the sentiment. Lots of opportunity to build new technologies and innovations, including healthcare, like a cheaper MRI machine. And that the point that he was making is that one of the, or I think you said the biggest driver of cost in that whole equation as you go from creation to product delivery is lawsuits, malpractice, product liability claims, and all of that sort of thing. And he's interested in my thoughts on it. Well, what I would say is I don't think it is the biggest. I think it is another part of the complicated equation that helps drive cost. Tort reform needs to be a part of the conversation. It has been here in North Carolina, both from medical malpractice standpoint as well as product liability. And you're right. Bold leadership finding the balance of the equities where the consumer can, in fact, be protected, reasonably so, and it doesn't provide an opportunity for exploitation. And at the same time, making sure that people that are doing it the right way do not have to suffer lawsuits of inconvenience and the cost in that. I think if we waved a magic wand tomorrow and the scenario that you talked about became perfect, and we could have a great big debate over what perfect looks like, but whatever it is, it's perfect. I think it would be a drop in the bucket relative to our overall medical spend. I think the largest issue is what we pay for and how we pay for it. And as I said in my remarks, we have a system now that encourages more things being done with little accountability as to whether or not it is yielding the intended result. And at the risk of being redundant, think about the example that I gave you, that we're paying for volume, we're paying for each activity. If you went to took your car into the automobile shop and said, I want you to tune it up, and it's $69.95 or whatever it is, $100, and you drove off the lot and it wasn't tuned up, and you took it back, would you pay another $100 for them to get it right the second time? Or the third time? Or the fourth time? Would you pay them for each spark plug that they put in the second time, the third time, and the fourth time, and each turn of the wrench? Of course you wouldn't. Now, I'm not making light of medical services being like, tuning up your car. But the repetitive principle is the same. That's what we do in healthcare. And we're doing it too often, and that has to change, and we're on a path to change it. I think that's where the real money is. Ounce of prevention is worth a pound of cure. If we could do that, 2.4 billion less claims that we would pay next year. So I don't want to leave us out of this. We got to get healthier, stay healthier. Okay, the question is, do I think that the quality of care may drop under the ACA construct paradigm versus what it is today because of the way the care is going to be paid for? No, I don't think so. There'll always be an example that you can point to and say, now that was a bad outcome. Listen, we have wonderful, wonderful medical providers in this country. And they are committed to doing the best job that they can do every day, all the time. Their world is under a revolution, just like the insurance industry world, just like the health IT world. And there's going to be a lot of change, and it's going to be very, very uncomfortable. But I do not believe that it will diminish one whit. In fact, I think, in my experience in this state and working with the providers that we have, their commitment to quality care is even greater, if it could be, than it was before. They understand how important this is. And so, no, I don't worry about provisions of the ACA driving quality down. I'm optimistic that it's actually going to drive quality up. Other questions? We've got about 7 minutes, I think. I'll look at the Sergeant at Arms over here and confirm. Okay, got a nod. Any other? Yes, sir.
You mentioned the problem with paying for each follow-up is a reverse incentive for doing unnecessary follow-up. And then you mentioned this episodic payment thing, perhaps a solution to it. Opposite. It doesn't introduce a new problem, which is a perverse incentive not to do any follow-up.
Well, no, first of all, that's where malpractice kicks in. So the standard of care has to remain the same. Now, let's level set who we're talking about here. There's always going to be somebody that's going to try to game the system and be a bad actor. I'm not talking about that paradigm, okay? So I'm talking about folks like us that are going to be fair and reasonable and try to do a good job and do the best you can all the time. But, so what I hear in your question is, what's going to keep them honest? So are you going to quit too soon in order to keep that margin of profit higher rather than lower? There's a risk. There's a risk for that today. I don't think it's going to happen. And what are the protections? Malpractice would be one. If you don't meet the standard of care, you will be held accountable for that. Number two, in order to be credentialed as a physician in the Blue Cross Blue Shield network, we look at your outcomes. We look at, if you're the physician, we look at the quality data. And if you aren't meeting the standards that we believe you should meet relative to being a quality physician, a quality healthcare provider, then we will drop you from the network. That's another way to provide consumer protection. Is it a perfect scenario? No, but that's two examples of why I think we have some oversight. Okay, let me go here and here, and then we'll see what time we have. All right? Yes, ma'am.
So with this, same thing on episodic care. I textile a couple years ago, and they were working on antibiotic sheets, if I remember. So it seems like this kind of bundling has driven innovation. And I was wondering if you had any other examples of the kinds of things, innovation that this has driven.
Well, there's a technology that is available now where you go into when you go into the doctor's office and you need blood work done. They give you a sheet. You got to go to the lab. You go across the hall. They draw the blood. 2 or 3 days later, you go back. You get the results, or at least my physician, they send me the results electronically. That's a good thing. And then if there's something we need to discuss, you got to go back in. Well, there's technology available today. You can go and have the blood work done. They walk right across the hall, do it, and while you're sitting there, boom, the lab results come back. Now, if and when that gets deployed across America, that's huge, huge savings. Oh, and the cost of the test compared to doing it, somebody driving and picking it up and taking it to a lab and coming back, and here you cut all that cost out, it's dramatic. There is, I was familiar, in fact, talked with the folks that invented, there is an implant that can go into the heart. I'll say this in a very unsophisticated way because I'm not a cardiologist. But that will transmit the pertinent medical data about the condition of the heart, bang, back to not only your computer but to the doctor's computer. That will help not only in prevention but also medical compliance. Little known fact, just footnote, people go to the doctor, they get their meds, they go home, and on a good day, our entire customer population, 70% of them will be compliant with their medication. If people will just, do what the physician says and do it well and do it like you're supposed to all the way to the end, that's a huge cost saving. Because when they're not compliant, guess what? They're back. A couple of examples. The list is so long, it's mind-boggling. Every day there's something else coming forward. Where were we? Yes, sir.
Yeah, it was kind of along the same lines. What it sounds like you want to move from it is paying on piece parts to paying on performance.
Correct.
Which is fine if all the parts are the same.
Right.
The problem is, if I'm going to be judged on my performance, I'm going to pick easy tests. I'm going to raise the bar on what patient I'll operate on. So don't you run the risk of, I can have a really high performance, but only pick to operate on 25 to 35-year-olds.
Well, we look at all that data.
That's why I want to tie this back to technology. The data analytics is extremely important.
Absolutely.
Because if you're going to judge them, put it in context for the audience. You don't want to put it in the context of a UNC football player taking all the easy classes.
There you go. Stand up and look at the camera when you say that.
but no, you can game the system.
Of course you can.
Position, and it's just, that doesn't seem like it's covered.
Well, let me say, yes, your point is valid, so I can't rebut your point, and I don't disagree with it. But look, folks, I don't care what we're working on. If somebody wants to spend their time trying to figure out how to game the system, yeah, they're going to figure it out. Ultimately, they're going to get caught. Somebody's going to figure out how to stop it. The question that we have before us today is, are we going to let the risk or the threat of that, which will happen in a minority circumstance, in my view, because there is sufficient oversight, and we're doing those analytics. We're not going to let our provider partners, if they decide they want to game the system, do it. We're going to catch them, and we're going to stop it. But we can't not get into the lab, try to build these new and different mousetraps, because somebody may figure out a way to game the system. It's happened in the history of the world. It's always somebody's going to try to figure out how to, cut a corner, and inappropriately gain from that. So let's leave this conversation, and again, I thank you for letting me have it with you tonight, focused on, again, innovation and collaboration, responsible risk-taking, to see if we can indeed make these better systems, devices that will advance and accelerate the revolution that we're all experiencing healthcare. I don't think we have any other choice. It is an absolute must-do, or it will bankrupt our country. And even if we didn't, I usually get a question about single-payer system, and I'll close on this in 60 seconds. Even if the government took it over and was running it itself, the costs are still there. It's not free. It will be paid for somehow, some way. So regardless of who the players are in driving the healthcare system, we've got to get our arms and mind around how to increase quality and lower cost. It's in our personal self-interest to do that, and it is in our country's best interest. Good luck Saturday. Go Pack.